My last review videos were all about handheld ultrasound, and I've now covered every major device on the market. If you haven't seen those, go check them out on the rest of the channel, especially if you're shopping for one. What I haven't covered yet is POCUS software. As AI has taken off, we've seen an explosion of it built into the ultrasound devices themselves and into separate companies whose AI plugs into the POCUS workflow to help with either image acquisition or interpretation. In this video, I'm reviewing AISAP's point-of-care ultrasound assisted diagnostics. It does something really cool. It gives you an echo read in seconds just from a cardiac point-of-care ultrasound. Full disclosure, I'm a consultant with AISAP, but I was convinced this technology was worth talking about before I ever signed with them. And this review is my honest take. They both don't control what I say here and have no idea I'm making this video. So, as a routine skilled POCUS user, why would I want an AI echo read when I'm already good at interpreting my own scans? A few reasons. First, a standard POCUS exam doesn't include much valvular assessment. I can put color on and spot regurgitations easily enough, but I'm usually not hunting for aortic stenosis. A lot of machines don't even have continuous wave Doppler, so they can't even do it. And frankly, it takes time, which is exactly what I don't have in a busy emergency department. And second, it gives you a quantitative ejection fraction. On a normal POCUS, I'm eyeballing it. Is EF normal? Is it mildly down, moderately down, severely? Sometimes I just want an actual number, especially to hand off to my cardiology consultants or inpatient team. In a primary care or cardiology practice, a number is something you can follow over time. And this matters even more for the novice user. A new user doesn't have to trust their own read when they're just getting their feet wet. They still need to look at the images and interpret at a basic level, but the AI can give them the quantitative call they aren't confident making yet. And if you're supervising early POCUS users in a clinic, it creates consistency. You can track something like ejection fraction over time and get the same quantitative read every visit without ordering a comprehensive echo each time. Now, it's important to be skeptical and look for the evidence, especially in something new like AI. It's there. There are a few large studies comparing ASAP against comprehensive echo with sensitivity and specificities around 95%. The most recent one reported 100% sensitivity and 97% specificity for detecting specifically LV dysfunction, and 100% sensitivity and 88% specificity for aortic stenosis. And I've put links to the studies in the description below. I think this technology fits a lot of clinical settings: primary care, cardiology practices, observation medicine, and clinical decision units, but also emergency departments, hospital medicine, and critical care. So you can see it's quite broad. It also works well at enhancing overall cardiac ultrasound done at a health system on the enterprise level. And I'll get into the specific scenarios where I think it best fits later on. But first, let's look at what the POCUS exam actually looks like for the AI read, because it's different from the typical POCUS exam you'd learn in a course.
Let's start with the parasternal long axis view. You don't have to start with this. This is just the view that I like to start with. So you take a B mode image, and you can take a couple to make sure that the AI has sufficient imaging. Then you put on color. And you make sure you have color of both the mitral and the aortic valve. And then you save a clip. I'm going to save one more. Great. And turn off color. Then you turn into the short axis view. Now, I'm at the mitral level. You want to go more towards the base to be at the aortic valve level right there. You can take an image of that. Great. Take even a second image just to be sure. Second clip, rather. From there, let's move into the apical four-chamber view. So you take one B mode image, just in grayscale like that. Then you take color. going to make the gate thinner. One is over the mitral valve. Take one more. Let's move over to the tricuspid valve. Perfect. And lastly, let's go to the IVC. You can see the right atrium on the right side of the screen. Maybe many of you will have learned it on the left side of the screen, but this is the cardiology method, but it still is the same. Let's take one more. And now we're all done. So when we go to submit to get it onto the system, I can choose the archive. So it can go right from the machine or right from your middleware, and you have all your images down there. And once I save it, it'll head right to the AISAP DICOM middleware platform. Now let's go to the platform on the computer and check out our results.
So here we are at the AISAP platform, pocus.aisap.io, username and password. And then when we open up, we can see a bunch of different studies that were done. None of them have patients associated with it, but if you were doing this on a patient and pulling it off a work list or putting your patient's information on the screen, it would go there. Let's go to the scan we did. What you end up seeing is all the different parameters that reads, as well as the views that it took it from. You have left ventricular ejection fraction, mitral regurgitation, aortic regurgitation, aortic stenosis, tricuspid regurgitation, IVC diameter. You have the atrial areas, aortic root diameter, and diastolic diameter, and the right ventricle fractional area change, which is, for those not aware, is a measure of right ventricular dysfunction. And then you have all the different views on the side. It recognized 15 loops, did not recognize one, and it finished analyzing quickly. You can see the whole scan took less than 5 minutes, even though I was explaining during the whole thing and took multiple images. And so it's very quick to do. So when you're ready to run the AI, it had all those views. Let's run AI. And then it told us already there's no tricuspid regurgitation. So it's able to tell us that there's a normal ejection fraction and see all these in green, no aortic stenosis. Green means that it's normal. So if you don't remember specific numbers or parameters, the system actually tells you, with green being normal and yellow being more abnormal and red being very bad. Here for the end diastolic diameter, you don't have the gender in there, so if I put male, and then it actually still is inconclusive, but that's okay. In a patient, let's say that you are only worried about the ejection fraction or aortic stenosis, you have that information. And so it couldn't necessarily read the end diastolic diameter with my images or the atrial area, but it still gives you a lot of the information that you're going to need. And if you're seeing someone, for example, with syncope, it may not matter exactly what the end diastolic diameter is, but still was able to read all these different images and came to the conclusion that this was generally normal. So that if this was an echo of a patient that you were seeing, then you can be very confident that you don't need a comprehensive echo in this patient because it will be normal. Once you have your AI report there, you can put continue. And now you can create a report that can be submitted and added to your electronic health record, billing, etc. You can find your indication that all has their ICD-10 code. We can use, if we use something like hypertension, for example, you can use the CPT codes, which is 93308, 93325. So those can be added. Our findings are already put in there. And this is something that if you wanted to change, so let's say you were like, okay, well, I saw the left atrium was this, or you calculated it yourself, you can always change and adjust for your report. So it gives you flexibility and not necessarily, okay, I'm going to trust the eye completely, even though it's very sensitive and specific, but I can adjust it myself. It has some sample images in there and any comments in there with a specific interpretation, add anything yourself, as well as the signature. This is a compliant report that you can submit for billing purposes. And once you do that, you can approve it and it gets submitted. Let's go back to the main page and look at some of the other scans that have done and some particularly abnormal ones. Here is a very poor ejection fraction where you can see that it is ejection fraction of 19%. This was somewhat severe CHF, had moderate mitral regurg, large IVC. And so you can see the different mild aortic stenosis or an abnormal heart. And so this gives you all that information. So you can see all these parameters in here, even with abnormals. It's excellent at telling you. Here is another patient with severe left ventricular dysfunction and no aortic regurgitation. So you can see that you get these results pretty nicely. Sometimes there are some inconclusive results, but as a clinician, you can take that into consideration as whether that's something that requires a comprehensive echo or not. When I first heard about AISAP, the immediate place I saw real value was in patients admitted to our observation unit or clinical decision unit for syncope. So here's what happens at my hospital, and it may look like yours. A patient who needs observation for syncope gets admitted to the CDU, watched overnight, and we order an echocardiogram first thing in the morning. Our echoes get performed pretty quickly, but our cardiologists are slammed with volumes. The reads often don't come back until later in the afternoon. That means a patient who's otherwise ready to go home sits there longer, just waiting on the read. And this is where AISAP fits in. If the PA, NP, or emergency physician runs an AISAP point-of-care echo at some point during the CDU stay, and it comes back normal, with nothing that needs cardiology or admission, you can discharge that patient much sooner. And if you or your cardiologist still want the comprehensive echo, whether you're easing into the technology or it's just your practice, you can still order it. You just don't have to keep the patients waiting on it to result. Or you could defer that echo completely to the outpatient setting. It's also a great screening tool, and you can probably already picture where this goes. Heart failure is often silent early on, especially in hypertensive patients, before they start showing signs of volume overload. Now imagine getting that echo done right in the primary care office for a patient with hypertension, which is itself a CMS indication to perform an echo. You catch the heart failure much earlier. Maybe that convinces them to check their blood pressure regularly or take their blood pressure medicines, or get them on disease-modifying therapy and refer to cardiology sooner. Ordering a comprehensive echo on every one of these patients can be prohibitive on both cost and availability in urban and rural areas alike. A fast screening echo can make a real difference for these patients. Same story in cardiology clinics. A screening echo before or during a visit, tracking trends over time in aortic valve disease or ejection fraction, is a big help. Picture yourself as the primary care doctor, cardiologist, or internist in a clinic, and you may actually be one. Have the patient come in at or a little before their appointment time, get the screening ASAP echo done by a trained nurse, PA, or NP, and the results are waiting for you when you walk in to see the patient. No seeing them and then sending them off for an echo and making them wait, only to have them back to discuss the results. You're probably thinking of more scenarios already. In hospital medicine for a patient admitted with heart failure or shortness of breath, anything where an echo helps you manage their fluid status, you can see how having that read immediately would change your day. And it's fast, both the scan and the read. There's a ton of information that's given to you, but you can focus in on what matters for that patient in front of you. Possible PE, look at that right ventricular fractional area change. Managing heart failure or shortness of breath, check that ejection fraction. Worried about the valves, patient's got a murmur, you've got aortic valve assessment for stenosis and mitral regurgitation right there. In the right patient, aortic dilation might point you towards an aneurysm or even an aortic dissection. So where does this land? ASAP isn't replacing your clinical judgment or turning you into a cardiologist or echocardiographer, but it really gives you a really sensitive, expert level cardiac read in the moment at the bedside without waiting hours or days on a comprehensive echo. And that screening, that sensitivity is so important. And for the skilled user, that's the quantitative numbers and valvular assessments you don't get on a focus exam. And for the newer user, it's a safety net and a way to build confidence. For practice or health systems, it's faster dispositions, early diagnoses, and consistency across everyone who picks up the probe. evidence is solid and the workflow is quick and it fits a wide range of settings, I still use it in my practice when I need it. And I can promise you do it a few times, it gets really quick and gets into your workflow seamlessly. And if you found this useful, subscribe for more POCUS device and software reviews, as well as POCUS educational content. And I'd love to see your comments and questions in the comment section. Thanks for watching, and I'll see you on the next one.